So every air, it will try to come into this. And as it will become bigger, right? So P3 will be gone. Right? P3 will collapse. This is the normal nature. This is the nature of the alveoli. Right? So if we don't want only one big alveoli to be in function, the suffix will come. Very right, because this is a hypothetical situation. This doesn't happen. Actually, it happens when there is pathology now. So when we say lung has collapsed. So for example, when it happened, COVID second wave, my right middle lobe, it collapsed. Right? It collapsed. So why it should collapse? So from where every alveoli, right? Every alveoli has given up and thud, right? All of them, they're collapsed, right? There is no gas exchange. So oxygen straight away dropped to 82%. So I was gasping. Right? It was so difficult to breathe. So in this case, or happens in normal. No. This never happens to anyone, right? This is a hypothetical situation. What we are trying to explain is, if there is no surfactant, this would happen, right? But it doesn't happen. Why? Thanks to surfactant. But in case if there is, we will see a case of what is called as the RDS, right? Respiratory distress syndrome. So in babies, when we say that at the age when it is the 24th week, the surfactant it starts developing, and by the time when it comes to baby is of 35 weeks of intrauterine life, so surfactant is well properly developed. But what if the baby is prematurely delivered? So in that case, surface tension, this surfactant is not developed. So in that case, there is less of the surfactant. It's not so that it is zero, because if it is zero, then person will suffer. But there is less, but still baby will be having respiratory distress, right? Respiratory distress. So that's why a special treatment is needed so that you can really handle it. Asthma is different. Lung collapse occurs due to this condition when the surfactant is having problem. It can occur because of even other reasons also. Other reason which you already know, intra-alveolar pressure, right? And the pleural pressure. So because all of them, we talked about it that they are covered with pleura, right? So this is the intrapleural pressure. This intrapleural pressure, that is the pressure between the parietal pleura and the visceral pleura, this is negative. So that's why it is giving that suction effect. So it is keeping the alveoli, right? This is preventing the collapse. So if there is any hole into this, right, the bullet injury, stab injury, maybe because of infection, right, this layer gets ruptured. So as the air goes inside, this minus, it becomes plus, so, right, the lung starts collapsing. Typically in COVID, this is what used to happen. And the intra-alveolar pressure, this intrapleural pressure that was getting affected. Can the damage or collapse be repaired or again inflated? I survived. Yeah, it gets repaired. But yes, you have to go for tremendous, say, initial part would be treat the infection. Once you are recovered from the infection, once you are COVID negative, because that lung won't be coming back by itself. You need to do some very rigorous exercise. Else, your capacity, what is called as the vital capacity, that decreases drastically. So then it would be very difficult. Means day-to-day life is okay. But if you are planning to run a marathon, problem. Right? Lung collapse, it recovers. Lungs, so they are wonderful. Means there are, just remind me at the end of our today's session now, I'll show you that device. No. Permanent damage is only two. One, heart. Second, brain. Now you can run. Well, Nirman, it's like till date 118 medals, and 64 medals they came after. Today also I ran for 21 kilometers. Very soon 4 full marathons are coming, 42 kilometers. Liver to bindas, liver to is amazing. लिवर ट्रांसप्लांट में क्या होता है? लिवर ट्रांसप्लांट के अंदर if I've donated my liver to you, I won't be donating fully, right? It is like one lobe is there, so one lobe is given to you, that will become full-fledged liver, and then my liver, that partial liver, that will also grow up with me. So no worries, comes back. हाँ, liver grows, lungs grow. क्या बात कर रहे हैं? हाँ, दे तो मस्त है. हाँ, liver grows. तभी तो liver transplantation is possible. Why people donate? They don't donate liver, they donate liver. Non-stop run, almost non-stop. Means my capacity is to run non-stop for 17 kilometers. After 17 kilometers, I need some electrolyte or something to eat, or then I walk for about half a kilometer, and then once again the second dash. Before collapsing, P3 pressure should be lower than P2 air. No, when it is collapsing, this is like a black hole. In the black hole, if you remember, right, again, we'll deviate from the topic, but in space technology, there is something what is called as the black hole. The pressure, the gravitational force is so high that it won't allow even the light to escape, and that's why we won't be able to see, because we see any of the object when the light gets reflected from it, right? So we don't really see. That's why it is called as the black hole. These are the extraterrestrial objects, right, which are moving into the space. Head transplant, I have not heard. How is it possible? Movies में होता है, right? Especially वो कौन हिंदी सीरीज में, they do anything. So how long it takes to grow? 6 months. It takes time. It is a gradual, continuous process. I mean, liver donation is not a small thing. It's not a small thing. It's a very big, complicated process. And for about a year, person would be quite compromised. So as this would collapse, right? So pressure won't decrease. Why should it really decrease? Because as it is collapsing, as this R is becoming smaller and smaller, this pressure will keep on becoming bigger and bigger and bigger, right? Till it collapses fully. So then it has fully collapsed. Now there is no space. So this entire unit, right, it will stop working. Entire unit will stop working. This is collapse. This is what is called as the collapse. Now we move on to the second point. What would really happen when we go at this next level? And over here, next level is like these alveoli, they are not working. Means like standalone. There are blood vessels over here. There are blood vessels over here. Correct? These are the blood vessels. So here, all these are like RBCs, right? And these RBCs, their function is they will say, "Chalo, give us the oxygen and take the carbon dioxide from us." Right? That is the gas exchange. So give oxygen and take CO2. Think about this unit. What would happen? This unit has become so big. Right? It has become so big. Right? So over here, there is so much of air. There is so much of air, but the speed at which the blood which is flowing, right? So that is the same. So over here, there is so much of air. Air will say, "No, look, chalo, you take the oxygen." Everyone would say, give oxygen, right? They are taking, but they say, "Still, I got so much of oxygen." Because sorry, we don't have enough blood. So what really happens in this case? It is what is called as the perfusion. Perfusion means how much oxygen that is picked up by the blood. That perfusion is normal. All the blood, right? All the blood cells, they have been given the oxygen, but what to do? There is still so much of oxygen is left out. As the person does the expiration, that's out. So it means the air which is having oxygen, it goes out without perfusion. That means it is wasted. Bad. This is bad. And what happens over here? There is less air. There is less air, right? There is less oxygen. So let's say these are the 4 RBCs and there are only two oxygens, right? So one oxygen given to this, one given to this. They will say, what should we do? But the thing is, the blood is not waiting, right? It is constantly moving. So over here, this unit is called as hyperventilator. Hyperventilator. And this unit is called as the hypoventilator. So over here, the blood efficiency is wasted. Blood is wasted. Blood came all the way over here to get some oxygen, but unfortunately they have to just go. So in both these cases, it is not a very efficient system. Another important point is, as we say, that the smaller alveoli, they tend to collapse. Right? Smaller alveoli, they would tend to collapse. So when they shrink, this is another thing. I'm explaining the concept of what's called as the pulmonary edema. Today I'll be showing you the X-ray also. Immediately, the moment you see, you'll understand, yes, this is what has happened. Here is the alveoli. Right? All the cells are there, right? And over here is the pulmonary capillary. Right? So this one is the pulmonary capillary. This water layer, as it shrinks, it becomes, right? The whole thing becomes smaller. So due to pressure, right? You'll agree that there is increasing pressure. So when there is increase in pressure, it will be having a suction effect even on the capillaries. So from here, the fluid will start getting sucked, because what is in between? A very thin layer of endothelium, just single layer of those pneumocyte type 1, right? It is a single layer. It has to be single layer, na? Right? Then and then gas exchange can occur. But when it is shrinking, right? So there is so much of pressure. So these cells, they can't stop the fluid. So that fluid, it comes over here. So here, the fluid gets accumulated. Then there is a fluid. And this thing, when this fluid starts getting accumulated into multiple alveoli, so this is what is called as the pulmonary edema. So when alveoli shrinks, that is decrease in radius. Decrease in radius means increase in pressure, and that is the suction pressure. Right? Suction pressure. So fluid oozes through epithelium to endothelium, because it is a single layer and gets accumulated in. This is collectively the pulmonary edema. Means fluid collection. When someone says body mein pani bhar, well, body mein pani bhar gaya is a very, very vague thing, because edema can occur in feet also. Fluid is filled in alveoli during pneumonia. Very right. In pneumonia, I'll show you the X-ray. You just diagnose it. But yes, I'll show you that. Yes, you are right. It occurs. Achha, right? So this is how it. treatment though is there. Treatment is there. Because if it is, no, we'll come to the treatment part. Because first you need to understand the pathology, then the treatment part. Right? We never jump on the treatment because it is like cramming. Your friend has this? No. Which edema? See, sometimes don't go for the home remedies. Some things they don't have the home remedies, and one should never try to do that. Means if it is simple acidity, etc., so then it is okay. Otherwise, don't play with the system, because edema, as you have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. I mean, you have got 10 messages. See, if he is admitted, first thing is there must be a doctor. Let him do the best. And second, without knowing the case study, and in the history and the details and examining the patient, it is absolutely a grave mistake to even tell something about it. Because I don't know whether that edema is pitting edema or non-pitting edema. What's written after oosis? Oosis 2. Phroughch. Right? Oosis. So pitting edema or non-pitting edema, no one knows. Right? It is like I need to examine. That's what I'm telling. Diet in edema means what's the reason? What's the reason of that idea? So unless you don't know the reason, you can't comment. Because edema can occur due to kidney failure, edema can occur because of the respiratory system problem, edema can occur because of the right heart failure, edema can occur because of the interstitial tissue damage, edema can occur because of the impact, edema can occur because of the problem in the bones. What to say? So body mein pani bhar gaya? No. That is a very layman term. Just can't comment and should not. Right? You should not. उसने diet पूछा तो he has to ask the doctor because he must be doing the diagnosis. I gave you 7 reasons. Which one is the correct? What is he having? And second, just because you have asked, so this is, let's say this is the feet, right? So when there is edema, I'm just explaining one term, right? There are 2 things. One, what is called as the pitting. Pit matlab khadda. Right? Pitting edema and the non-pitting edema. Non-pitting. This is one of the initial examination. So you just press the thumb, keep it pressed for 10-15 seconds and then take it away. If you find that yes, there is that khadda, clearly you will be able to see. So that is what is called as the pitting edema. And if the moment you take your finger back and skin comes back to normal, so that is called as the non-pitting. And this will be one of the diagnostic point. Okay, chalo. So coming back to our topic. So it is like when the fluid gets collected, right? When the fluid gets collected over here, so obviously there would be a trouble in the gas exchange. So oxygen, CO2 affected. True? Right? When the fluid is over here. Very right? So the gas exchange, that is. So now the solution is the surfactant. So how this surfactant that would really be working? So as we discussed, that surfactant, it is secreted by type 2 pneumocyte. Type 2 pneumocytes. Now these type 2 pneumocytes, when they secrete, this is a combination. 90% of it is the lipids. And only that 10% of it is in the form of protein. Now they are like onions. They are like onions, right? They will be forming multiple layers, one layer, two layer, three, four. And that's why in body, anything which is having the layer, right? That is what is called as the lamina. Lamina means layers, layers. So anything which has got layers, so it is called as laminar, right? That means it has got layers. So that's why these are called as the laminar bodies. They are called as the laminar bodies. Where are they? They are pretty deep. Right? They are pretty deep, but as they come onto the surface, so over here, we just say that this is the alveoli. Over here, this is the cuboidal cell, which is leading to release of this surfactant, right? So these small things, what I'm drawing over here, these are the laminar bodies. Right? These are the laminar bodies. That means laminar bodies. If I just zoom this thing, this is the cell. So these layered things, they are inside the cell. They are called as the laminar bodies till they are inside. But then they will try to come out. Right? As they come out, they change their shape. Right? They form multiple tubules. Over here, as they come, these lamina, as they come on the surface, when they come on the surface, they'll start forming the tubes. These will be the tubes. So that's why collectively, this is a type of protein, right? And that's why they are called as the tubular myelin. Tubular myelin. It is this tubular myelin which is of utmost importance. So if we say that this particular lamellar body, right, in its core, right, in its core, that is this over here, in its core, there is lipid. There is lipid. So first thing, what it will be doing is, this surfactant's technical name is that there are two palmitoyl. Right? There are two palmitoyl. So this one, this is 1, this is 2. So we'll call that P1 and P2. So when they are 2, so we'll be calling it di. So it is called as the dipalmitoyl. Then over here, there is a phosphate bond. So that's why we'll say phosphatidyl. Phosphatidyl. And then there are apoproteins. Apoproteins means these are the special proteins. You can say it like 1, 2, 3, 4. There are 4 proteins. I'll explain again. Right? What we are drawing is the surfactant. This is the full surfactant. The molecule of surfactant. So this P1 and P2, because these are the palmitoyl molecules. So there are 2, so that's why P1 and P2, so that's why dipalmitoyl. Over here, there are phosphate bond. So it is called as phosphatidyl. And the choline. So these are all proteins. There are 4 proteins. Out of these 4 proteins, they are also called as the apoproteins. Right? They are also called as these are the proteins, right? A, B, C, D. Collectively, they are called as the apoproteins. The proteins which are protruding out from and they are linked with that lipid. Right? Not only this much, there is something extra. There is something extra, and this is a very special thing, and that is called as the IgG. IgA, sorry, my mistake. IgA, right? IgA is immunoglobulin. Immunoglobulin is a fancy word, right? It's a fancy word for antibodies, right? Antibodies produced by B cells, right? B cells. So these antibodies, they are, yes, that's right, they are for immunity. Lipid is in the cell, that's right. Cholines are proteins, A, B, C, D, plus I'm adding some more apoproteins. Right? So these are antibodies, that's right. These are Ig, they are collectively called as Ig, right? Immunoglobulin, but there is IgG, IgA, IgM, IgE, IgD, all these type of proteins. All these proteins, they are having their specific functions. So over here, this is the IgA, which is sitting, which is connected in small amount, but it is present over there, but its function is very big. And the most abundant protein, that is the albumin. That is, this is the complete structure. So IgA and albumin, they are also protein. Right? So in apoprotein, we'll be adding IgA, that is immunoglobulin A, that means the antibody, right? And the albumin, which is for the nutrition purpose. Now let's break this down, that what are the functions of everyone. And that is the beauty of the entire system. It's so simple. If I draw a line in between, and in just 5 seconds, you will understand the importance of it. This is the water layer. That's the water layer. Half of this P1, P2 stays outside. The rest, all of them, they are inside. And how is it possible? Very simple सी चीज. They don't love water. They say we'll stay away from the water. So what we'll be calling them? Hydrophobic. Right? And all these proteins, they love. So we'll be calling them hydrophilic. That's the story. That's the story. Right? Now, what about IgA? We said that it is for immunity. Very right. It is for immunity. It is for immunity. In few minutes, we'll be talking even more about immunity. Though we'll not be going into the detail of immunity, that it's a complement system, etc. But we'll be talking about that what it can really do. It plays a wonderful role, amazing role. And that is the reason that when you are running on the road and a truck comes, right, whoop, right, black smoke, right, so many of infective things they are, and obviously you'll be breathing in. It's not so that once you are back home, then start coughing and then there is lung infection. No, nothing happens because it was settled at that point only, right? Thanks to IgA, right? So any of these kachara, right, they all are handled by IgA instantly. Otherwise, every day we shall be falling sick. Every day, right? You go out and then you'll fall sick. This is the reason why it is said that why the immunity should be powerful. One of the reasons. Right? This is one of the reasons. Okay. So as I said that this is the water layer. This is the water layer. So think it like that there is a creature who is sitting in between, right? And these two tentacles which are outside, right, they will remain outside the water, and these four, they are inside the water and they are holding. So they will be now, let's take a bigger picture. A bigger picture would be this. If this is the layer, these were the water molecules, right, which they were creating so much of tension, surface tension, and they were tending it to collapse. Now things have changed, right? Here comes the surfactant in between. And over here is over. But its extensions, they are outside the water. And they'll say will remain outside. When they are outside, it means they are having upward pull. They are inside, they are having downward pull. But because they are having upward pull, so many of them, right, so many of them, they are there. Those who are having that upward pull, due to this hydrophobic nature of this phosphatidyl. It is the phosphatidyl group. And we have got two. That's why it is 2-phosphatidyl. That's why you call it diphosphatidyl, right? P1, P2. That this is the phosphatidyl, two groups. And they are staying outside and they are giving the upward pull. Now, if there are so many of them, what would happen? Surface tension would decrease. It will break the surface tension, right? Because inside, so they are holding their feet very strongly. They are into the water, right? But outside, they are telling that no, will not go in. So this area, this phosphatidyl is staying outside, And that is, the result is, it would break surface tension. That is the importance of surfactant. Phosphatidyl is outside water, outside, because phosphatidyl is what? It is hydro, it is hydro with phosphatidyl is what? Hydrophilic. It is phobic. That's right. It is hydrophobic. That's right. This cell is in liquid. Hypothetically, no. This is actually present. This is the surfactant. No? This is the surfactant. So this is not hypothetical. Actually, it is happening at every second, millisecond. Your alveoli, my alveoli, this is what is happening. Constantly, right? Type 2 pneumocytes, they keep on secreting it. This is normal. Yes, this is normal. This is which is happening in you and me 24/7 till we live. Right? 24/7, 365, and the years. Right? It is happening stop. Because in alveoli, it is not static. It is constantly produced. Because secretion is coming now. These cells, they are secreting. When there is any change in the pressure, the fluid will come. But the surfactant, they are type 2, is also secreting. So breaks, right? And all the alveoli, they remain into that shape. So actually, if you visualize, it is not so that all the alveoli, they are like sitting like this and exchanging, right? They must be pulsating, right? They increase, decrease, increase, decrease. Right? This cell is on surface of alveoli. Inner surface. I mean, if I draw the water over here, if I draw the water over here, so they will be sitting here, right? Here, and that's how they will be sitting. Right? Liquid inside is plural, nahi dost. Plura yahan pe nahi. Plura is outside the alveoli. Plura is here. Acha hai pucha. Don't worry. Plura is outside. Plura is the covering. Right? Plura is the covering. So plura, that will cover it. This is inside. Right? These are inside alveoli. Surfactant, no confusion, is inside alveoli. Got it? That's right, Ashish. It avoids collapsing. Because see, once the surface tension is broken, so collapse avoided. Because it was the surface tension who was creating this trouble. So now, all good. It is not collapsing. Right. One more thing, we talked about, when we'll be discussing the immunity, I will be talking about apoproteins in tremendous detail. Apoprotein A, it has got big role, right? And apoprotein D. So they are called as the opsonine, the process of opsonization or opsonine. So what opsonine is? Very easy thing to understand. They are sitting, right? They are sitting inside, right? These two, they are sitting inside, right? If there is any bacteria, right, it comes. These are P1, P. A bacteria comes, right? And that bacteria, it comes on the surface, and that bacteria goes into the fluid, and then his plan is to infect everyone. Right? So the moment this bacteria comes, the immunity is activated, and it will send the team that eat it. They are called as the macrophages. But these bacteria, so they will keep on running. This is the point when this A and D, they come into picture. They will catch hold of it because there are specific receptors on it. Right? They will catch hold of this bacteria. Right? They'll catch hold of this. And then they will call. Macrophage, come, jaldi aa jao, kha jao isko. Right? So those macrophages, as they receive the SMS, right, there is a whole system behind it. But as they receive the call, right, immediately those macrophages, they will come. Now, what these macrophages will do? It will, this D, right, this apoprotein, it will say, okay, I give you the table, right, यहाँ पे बैठो. अब ये कहीं पे भाग नहीं सकता बैक्टीरिया. So this is the macrophage, and that is the process of phagocytosis, right? How, right, it eats. So इसको भी पकड़ के रखा है बैक्टीरिया को, and then the macrophage is also given the receptor कि हाँ आराम से बैठो and eat him, right? So this macrophage, which is a big cell, right, it eats. So any of the substance which is like on one side where there is, it is called as the pathogen, right? Something which is generating the pathology. Pathology means abnormality from the normal. So this is pathogen. This is pathogen. And over here, it is connecting macrophage or neutrophil. Macrophage. Those who are like, they eat these pathogens. So it is this apoproteins, they are over here. दोनों को बांध के रखा. So ये bacteria भागना चाहिए. So that this macrophage can lavishly eat this pathogen. All these things, right, they are collectively called as the opsonins. Opsonins means which facilitates phagocytosis. Right? You'll find that in the textbooks, they just write one sentence. Opsonins are those who facilitate. Facilitate means making it easy. Facilitate the process of phagocytosis. So this is one of the very powerful defense system. So that's how things they really go. So we saw that when there was high surface tension, so that was leading to collapse, right? Collapse. Still, if you go into bit more detail, can we say it like this? That if the surfactant, for some reason, if the surfactant is not present, right, so there would be increased surface tension. Right? There would be increased surface tension. Increased surface tension will lead to increased collapse. So when there is increased collapse, that means will the lung be able to, say, come back to its original state? No, correct? And the ability to stretch, right? Ability to stretch, we use the word, right? We learned the word, that was compliance. That is called as the compliance. So what was compliance? Compliance was ability to stretch. But when there is so much of pressure, right, everyone is collapsing, then that ability is decreased. Right? Ability is decreased. If this thing happens, what would really happen? Right? Chest will try to do. मर तो नहीं सकते ना. The brain will say, गाली बोल के, muscles, what are you doing? काम करो. Then chest will work more. Right? So that at least some expansion occurs so that gas exchange can happen. So over here, the chest muscles will overwork. When the chest muscles overwork, right, you just expand it slightly, even something, so that it is manageable. Something can be taken in, some gas can be exchanged. So this is where the chest size is bigger, but person is unable to breathe. You'll find that they will be having huge chest. When I'll show you the X-ray of emphysema, you'll find such big chest. Yes, but all those alveoli which are inside, they are practically useless. They are all loose. Right? Practically, they are like, there is hardly any gaseous exchange which is happening. So even if the chest is bigger, right? It is not efficient because the compliance, the ability to stretch has decreased. It is the chest muscle which are trying somehow. It is exactly like that python, right? But then it is like I try to expand the chest. कि चलो थोड़ी बहुत तो air आ जाए. So that is the survival. That is the survival. This is what really happens when person tries to survive. Right? In forensics, when we'll be discussing the forensics, it is like every day opsonin facilitates phagocytosis. No, I'll write it again. Phagocytosis. So in forensics, when we'll be discussing, every day it will be a case, right? I explain forensics like a real case. When someone is strangulated, gala daba ki jo maar de, what happens? Right? You will just see that even if someone has used the gloves, but you'll be knowing it within seconds that this is strangulation. So now, whether the person, कई बार movies में दिखाते हैं, but in reality also it happens that person is strangulated and फिर उसको फांसी पे लटका दिया. Correct? So then how do you know that whether the person was murdered or he or she committed suicide? This is where your anatomy knowledge will come into picture. And this is where, like next time I'll show you some of the cases also. Because it is where the anatomy, physiology, everything will come into picture. And that's where it is the practical implementation. Because your one statement will make a big difference. Right? That's what really happens in this case. Achha. When the surfactant is present, I'll change the color. Right? When the surfactant is present, so there would be decreased surface tension. Right? So there is decreased collapse. There would be ability to stretch, so compliance would be increased. And the chest muscle, they don't have more work. So they become normal. Right? This is what really happens. So very crystal clear that why all these things they really happen. We talked about the respiratory distress syndrome. Right? Respiratory distress syndrome. Now, in respiratory distress syndrome, I will be discussing this thing once again, like how in Calcutta the first saved suicide. That was so in Calcutta. What happened was they were like monsters, because apart from suicide, her entire pelvic girdle was broken. Entire pelvic girdle. If you really see the postmortem report, I mean, you'll get shivers. It's like, means what do they try to do? I mean, there were so many evidences. Anyway, so that was like even monster won't be. Yeah, I mean, very controversial thing. That's why I'm not reading your comment. Sorry. But yeah, everyone knows. Everyone knows. Yes, you are right. 100% right. It's painful. When I was teaching this psychiatry now, so I was telling that why it really happens. Why it really happens. I mean, there were some strange cases. Though some cases they are very amusing, but some cases they are very painful. So those serial killers, right? So Alan Gautier, if you have heard of it, his other name he was also known as Charles Shograj. He did 76 girls were murdered. 76, and that's why he was also called as the bikini murder. And that case was like, he was bailed out at 90. That is the thing. I mean, so many innocent girls, they were killed. And then again, they are getting the bail. Anyway, so this is the respiratory distress syndrome, which is seen in infants. So reason behind it is that surfactant its production, I mean, I'll not say the production, its synthesis, right? Its synthesis. That means the process starts at the 24 weeks. 24 weeks. This is IU. IU stands for intrauterine life. Intrauterine life. Right? When this baby, when this is inside the mother. So at 24 weeks, that process starts. But actually, surfactant is full-fledged form and in action only at 28 to 32 weeks. So by 32 weeks, so it is properly formed. Right? In some cases, it is 20. So after this, if the baby is delivered, it's fine. But what if it is before that? So this is where there would be premature baby, that would be having less surfactant. Now you know what can really happen. Premature baby would be less surfactant. That's why they'll be straining. And they'll be difficult. So that's what really happens. Now, when we'll be learning the fetal circulation, this is one of my favorite topics. I mean, you will feel like saluting the God. I mean, what are the things which really happens the moment baby is born, and that first cry, right? What baby cries, and when the baby cries, how the entire fluid mechanisms, dynamic systems, right? Everything starts changing, and the baby starts living independent life. Right? Premature baby has complication in breathing and intelligence. Absolutely right. Absolutely right. Premature baby, they have got this. Achha. So when we say that it is the respiratory distress syndrome, and that respiratory distress syndrome is because of this decreased surfactant. So when the surfactant is decreased, one, as we said, that there would be the problem of compliance, right? So there is decreased compliance. There is a risk of pulmonary edema. There is the risk of pulmonary edema. So today, when I'll be showing you that X-ray, you'll mark one thing. Right now, I'm not telling you. Right? I want you to figure it out. I want you to find it out. This is there. Right? It would be very interesting. And third thing, because the surfactant is there, that can we say that this particular baby will be more prone for infection? Right? Is more prone. Prone means or the vulnerable to infection. Till this point, we were telling that okay, surfactant is doing this, that, but yes, because there is less immunoglobulin, there are less apoprotein. So that's the problem. You know? So this is what can really happen. This is the thing why the surfactant is so important. Now I show you those X-rays. Every X-ray is a very classical thing in itself. See the full X-ray. So here is the first X-ray. Before you jump onto any of the conclusion, let's learn something new. And I'm writing on it. Counting the ribs. Today, first thing which we'll do is learn to count the ribs. Which rib is which number? We need to know the number. You know? So here it is. Can we really see that, okay, here is the first rib. I'm drawing. If you want, I can zoom this thing. This is the first rib. Then all the way, right, say this is the second rib. And the third rib. And the fourth rib. Can you really see it? Right? What I'm trying to emphasize is try to watch the anterior end. Now, it is difficult in this case. Reason? I'll zoom that. Just give me a minute. I'll zoom that. It is difficult to see the anterior end because this patient is of osteopenia. This is the osteopenia. Must have guessed by now that this is a female patient. It's a female patient for this breast shadow. So this is a female patient, old age, but this is a case of osteopenia. Osteopenia means thin bones. Thin bones because of steroids. This patient was kept on steroids. So steroids, that affects the resorption of the bone, right? So that leads to osteopenia, thin bones. What we see over here is, I'll now just zoom this thing. Now you should be able to appreciate. And I'll just draw this. And this. Can you see this end? This end. That is the anterior end. See, visualize it. This and this is the ray, right, which is coming from the back, right? Think this. See this ray. This is starting. This end is the posterior end. This is the posterior end. As that ray goes all the way, and here it is. Here it is. This is the anterior end. Can you see it? Right. I'll remove now all markings. And I'll just write 1, 2, 3, 4, 5, 6, right? So that we count the ribs. Great. So this is this part, right? This is rib number 1. Means I'm writing the anterior end, right? These are the anterior end. Watch this. This is the rib number 2. Not this, huh? Not this. Right? These are the posterior end. So ribs from the back side, they are coming forward, and then there is a costochondral junction, right? Costochondral junction, and then there is cartilage. Cartilages, they are not seen. So that's why we'll feel that, okay, only the anterior ends are seen. Practically, real ribs, so they are there, right? There is cartilage. Unless calcified. The last time when we saw that there was ossification of those cartilage, right? So then we were watching all the ribs as if they were approaching, right? We saw it like they were approaching over there. Right? You remember last time? We saw the last X-ray. So over here, this is completely different. The density of the bone has decreased. So this is 2. See this? This is the rib number 3. See this? This is rib number 4. Watch this. Rib number 5. This one, rib number 6. And this one is rib number 7. Right? I have put the numbers and now I'll remove the markings. I'm about to explain one very vital concept, and if you understand this, it would be like you'll be able to say even write a report like a radiologist. Something sometimes say learned in a very hard way. I'm trying to make it as simple as possible. So can you really identify anterior ends? Yes, no. If there is any doubt, right, just for the practice, try to identify the on the left side. On the left side, try to identify. Can you really see? I know it is a bit difficult because the patient is absolutely osteopenic. Wait. In this way, it is wonderful. See, without delay. See, right? See, this is the anterior end. This is the anterior end. So, makes logic, no? Anterior end comes like this, and the posterior ends, they are like this. Posterior ends, they are more horizontal, right? See, they are more horizontal, right? And the anterior ends, they will be dipping like this, they are the anterior ends, right? So this practice, you can do it on all the X-rays. नहीं अभी don't worry about the dextrocardia. आज कोई dextrocardia नहीं, right? None of the cases of dextrocardia. Identify the ribs, right? Okay. I'll write down once again 1, 2, 3, 4, 5, 6, 7 again. Next, what you have to understand is the clavicle. There is a line which is called as the mid-clavicular line. Mid-clavicular line. Mid-clavicular line. What's the big thing? That's the clavicle. Right from the middle, if I draw a line, so that is called as the mid-clavicular line. From here, all the way down, so this is mid-clavicular line. Simple, right? Here is the full clavicle, the middle point, here is the middle. Okay, this is the mid-clavicular line, right? From midpoint of the clavicle. No, no, nothing is dislocated, everything is fine. The patient is in bad condition, very, very critical condition. That's why every time we cannot expect that patient will be. Patient was unable to stand. So everything is fine. What I'm explaining is the biggest thing what you see the diaphragm. The diaphragm is here, right? Diaphragm is here. Right? The diaphragm is here. Lowering of diaphragm. So this is the marked thing. There is lowering of diaphragm. But how to say that? What is the evidence that the diaphragm is lowered? This is PA view. Boss, don't keep on guessing. Koi chinta mat karo. Understand what I'm explaining. The one line, the normal position of the diaphragm is, right, that diaphragm should be at the level of, in mid-clavicular line, it should be between 5th to 7th rib. So, what I mean to say is, if I draw, this is the first rib, this is the second rib, this one is the entry end of third rib, this is entry end of fourth rib, this is the fifth rib, this is the sixth rib, this is the seventh rib, this one is the eighth rib. Now, ninth rib, you find it difficult to watch, right? But at least you can say that it is at mid-clavicular line. This is the mid-clavicular line. At this plane, diaphragm is definitely lowered. What would be the real position of the diaphragm? The real position of the diaphragm, as we said, that the normal position of diaphragm, remember anterior end, okay? So anterior end of ribs number 5 to 7. So it means the diaphragm is normally something like this. This should be the shape. The diaphragm should be something like this, right? It should be slightly lower because of the heart. So like this, right? It should be lower. It should be higher. Right? This is the normal position. Normal position of the diaphragm. This one is normal position. So diaphragm is definitely lower. Why the diaphragm should be lower? It is because of the hyper expansion of the lungs. Hyper expansion of the lungs. Typically, what is seen is in the case of COPD, chronic obstructive pulmonary disease. So lungs have tried to expand, right? It is what is called as the hyper expansion. Lungs are inefficient. So in order to get some oxygen, they have expanded themselves. So this is the typical case of COPD. Patient is constantly coughing, right? So much so even the steroid, massive infection, right? Even the steroid bones have become thin. And typically over here what we see is the diaphragm has become lowered. So this is typical what is called as the lowering of diaphragm. Another thing, diaphragm has lost its shape also. The dome of the diaphragm, they are like this dome. They are called as the dome. Normal position, they are called as the dome. Right? See, see over here, right? These are like the dome of diaphragm. They are like curves. Watch it over here. Watch it over here. See, they are flat. right? So it is not only the lowering of diaphragm plus flattening. So never forget, and I hope this concept is clear, that the dome of the diaphragm should intersect the mid-clavicular line between this 5th and 7th rib. It is this zone in which it should really cross, right? So they have become so low. And plus the osteopenia. Osteopenia, it's okay if you don't diagnose it right now, because as you will see more and more X-rays, just because it is a subjective thing. Just you look at it and instantly you say that just check it D3 calcium and maybe. Okay, so this was the first one. Now see this. Now starts the very interesting piece. Can you see? Let's see. Wherever there is black, that means it is a lung. There is air, right? So this means there is air over here. Can you really appreciate this particular area? This one. Now I remove the marks. There is no air. This is consolidation. Name itself is solid. It has become solid. That means there is no air. There is no air in many of the alveoli. That's why, because of the lack of air, when there is air, the X-rays will be able to pass through. So it will be giving this black area. Over here, it is white. That means there is so much of tissue. If there is so much of tissue, so that is what is called as a consolidation. So this is pneumonic consolidation. Because of pneumonia, because of infection, the alveoli, they are studded with fluid. So much so that they are not allowing any gas to pass, and they are not allowing any X-rays to pass. But if you watch carefully, there is one very interesting thing in this. I'll just zoom this thing. Can you see the air bronchogram? What is air bronchogram? Air bronchogram is that this is the hilum, right? This is the hilum. See this blackish thing, right? Blackish thing, and it ends at this point. Pass. Can you see it? I now remove it. You have to just see, now you should be able to appreciate this area I'm talking about. This is what is called as the air bronch. That means there is some air which is reaching to that area, right? But big bronchi. But after that, everything is consolidated. So air is unable to, otherwise, so it should really distribute like this. Right? Nothing is seen. First, we just see the air bronchogram up to this level. First, some minor, right? Not much. So this is one finding, that is air bronchogram. Let's watch one more. What do you see in this? What is your first impression? You see this? Watch. Giving you the hint. Watch the left lower lobe. So this is left. Do you find something unusual here? I'll just hint. You find something here. Diaphragm is fine. Diaphragm is superb. Diaphragm is fine. Not a problem. Above the diaphragm, whiteness which you see. Notch is okay. The heart is completely normal. This is heart. What I'm telling you is this whitish portion and then this whitish portion is all one. It is because on X-ray, right, there is a big mass over here. This is what is called as the basal lung consolidation. This is called as the basal lung consolidation. Sometimes these consolidations on the left side, they are hidden behind the heart. Means no air. That's right. So that's why this is looking whitish. So here, this is partly blurred by heart. Blurred by heart. It's totally fine if this thing is not diagnosed by you at this point, right? What I'm trying to tell you is that at times, say you need to watch the things very carefully. And now you can appreciate that, look at this lung, which is absolutely fine, right? And compare it with this lung. So immediately you will see that, yes, it is this portion, it is not as blackish as this, right? ठीक है, चलो यहाँ पे heart आ गया. But at least this portion, that should be as black as this. It's a clear difference, correct? There's a clear difference. As you'll see more and more X-rays, right, to be more clear. But right, this is very typical basal lung consolidation. Next X-ray is very wonderful. So good, right? You learn just from this so many things. What will happen to patients? Infection. So you need to give them good antibiotics, powerful antibiotics. That's right, trachea. But why the trachea should be pulled into that area? Now, if we go for the anatomy, very right, very good, very good. See, the right lung, it has got upper lobe, middle lobe, and the lower lobe, correct? On the left side, there is upper lobe, there is lingular lobe, it is called as the lingular lobe, right? And the lower lobe. Right? Exactly. This is what you need to see. This is what, that is the horizontal fissure. This is the horizontal fissure. Horizontal fissure. Now see how smartly you have started writing the diagnosis, and you are 100% right. You are 100% right. This is, those who have written, shabash. This is upper lobe, but you need to specify right upper. Right? So it is right upper lobe consolidation. Don't take anything for granted. Okay? It's खुश होके upper lobe consolidation. On the side. Okay? So this is upper lobe consolidation. And this thing, again, it is because of the infection. So the diagnosis in this case is because one specific lobe is involved, correct? So that is called as the lobar. And this is the lung infection, right? See that hardly there is any air is going, right? It is fully, absolute consolidation. The upper lobe is fully involved. So that is what is called as the lobar pneumonic consolidation or the lobar pneumonia. Simple words, just write. That is also the commonest reason of lung infection is Streptococcus pneumococci. Right? So that is the common strep infection. It is called as the Streptococcus. Coccus means they are round, and pneumonia. So that is the bacteria which causes this infection. Commonest infection. This is the one. Without watching the X-ray, so it cannot be commented. It's difficult. But still the X-ray is in front, I can't comment. This thing. This thing. What's the diagnosis? of the diagnosis. Again, DX means diagnosis, right? Whenever I write DX, whenever I write DX, so that means diagnosis. DX is diagnosis, RX that is treatment, and CX means complication. Array, sub was all. Stop. Yeah, this is what. Array nahi. हाँ चलो, this you found out. This is the AP. ठीक है. This is AP. Right? Which fissure is this? Horizontal fissure. Here is the horizontal fissure. Horizontal fissure के नीचे which lobe is there? Horizontal fissure. This is the upper lobe. Array those. Which lobe is this? This is the. अरे lower lobe. फिर से lower lobe. अरे lingular तो मेरे भाई. It was on the left side. L for L. This is lingular. Middle lobe. That's right. It is the middle lobe. This is superb middle lobe consolidation. Right? So that's the horizontal fissure. See how easy it is to diagnose. Right? So this is the horizontal fissure. Horizontal fissure is always seen very clearly. Right? Horizontal fissure. So upper lobe is fine, and you can confidently say that this is the middle lobe consolidation. Great. I give you one more sign. Remember, right? This is one thing, horizontal fissure, and just below, middle lobe will always be below horizontal fissure. Right? So it is below this. So this is one thing. Second thing, what you need to, if you want to stamp on the diagnosis, no way, middle plus lower, bilkul nahi. Wait for the lower lobe. Wait. Lingular lobe would be here, left side. So AP anteroposterior. So usually this view on chest X-ray, it is PA view, posterior anterior. So when the patient is standing in front, there would be X-ray plate, and from the back the X-rays are coming and the X-ray is taken. But in this case, patient was unable to stand. Right? So that's why when the patient is lying on the bed, niche X-ray plate is slided, and from the top the X-ray is taken. So that's why this is the AP view. AP view is always taken when the patient is in very bad condition. Array, lower lobe, why are you jumping on the conclusion? Don't jump on the conclusion. Lower lobe. First understand that what is middle lobe. Right? Wait. This is 100%. There is no lower lobe. You know that? So always go systematically. The middle lobe, as I was telling, that if you really want to stamp your diagnosis, 100%, this is middle lobe only. The right heart border is blurred. See the right heart border. Can you see in this case how nicely you see the right heart border over here? Right? This is the right heart border. Watch in this case. Where is it? It should be here, not seen. Because anatomically, the heart is like this. The heart is like this. So when they both are so near, right, they both have become like there is no air. So that's why this middle lobe has its image has merged with the image of heart. And on X-ray, heart, what I'm telling is right heart border. Heart is on the left, but this is which border? This is which border? The right side border. Na? Right? So simple. See, this is the heart. Now complicated kahan hai? This is the right heart border. This is the left heart border. Right? The heart is on the left side. Heart is into the center. Actually speaking, heart is into the center. It is only the left ventricle because it is so big. That's why it protrudes onto the left side. Otherwise, the heart is in the center. Right? So, जो ऐसे करके दिल दिया वो ऐसे नहीं दिल दिया जाता. Right? This is exactly into the center. Only it is the left ventricle which is going towards the left side, and this is where the apex peak is. So when you put the stethoscope, you'll be able to hear very prominently, right? And you'll be able to see also that what's called the apex peak. We'll see it in cardiology. So over here, this border, right? This border is blurred. So over here, we are unable to see this border, right? Unable to see. So that is the confirmatory sign that this is the middle lobe collapse or the middle lobe consolidation. Middle lobe consolidation, not the collapse, consolidation. Collapse, I'll show you. This is consolidation. Things have built. Okay. Now see, this is your lower lobe consolidation patient. See how typical it is. Because if you see the anatomy, the lower lobe is situated a bit posteriorly. So here, if you, can you see the horizontal fissure? No, not seen. Right? So let's write the findings. Horizontal fissure, not seen. Correct. We can see that yes, there is definite opacity. Clear opacity is there. That means there is consolidation. You need to decide whether it is middle lobe or lower lobe. Right? And every time, don't keep on jumping on whether male or female. Right? Watch the things which are more important. I didn't want to say that, but so this is horizontal fissure which is not seen. That is one. And second, is the right heart border seen clearly? Must absolutely fine seen now, right? So right heart border clearly seen. So it tells that it is not a middle lobe consolidation. It cannot be even upper lobe. So 100% this is a lower lobe consolidation. But then we need to confirm it. We need to confirm. Lower lobe consolidation, that is our diagnosis. But how? The confirmation is that the right diaphragm is not seen. That is blurred. See, confirmation is the right dome of diaphragm blurred. Compare it with the opposite side. How clearly must you can see the left dome of diaphragm? Where is the right dome of diaphragm? There is total consolidation. So this entire thing is consolidated. That is the lower lobe, because lower lobe rests. Right side heart border seen. It is seen. That's what I said. No? So that's why it is not middle lobe. I'm getting it. It is not middle lobe consolidation. Right. So this is the simplest method to figure out. Just you see the X-ray and instantly you say that this is a lower lobe consolidation, or it was a middle lobe consolidation, which the horizontal fissure is clearly seen, and the right side of the heart border that is obscured or it is blurred. And this is the upper lobe because clearly horizontal fissure is seen. Nothing is to be done. Right? It's clearly the case of upper lobe consolidation. So this is upper lobe, this is middle lobe, and this is the lower lobe. Now can you diagnose? Right? Okay. Watch this. What do you feel? Which lobe is affected? What you saw, it's not all. It's not all. But there are two things. This is a patient in which there is massive infection. It's multiple lobes. not all, but we'll see multiple lobes. The lobes which are affected over here is the right middle lobe. Right middle lobe, but it is not fully involved. When it will be fully involved, it will be involving, it will lead to that blurring of this. So at that point, we know that now the lobe is fully involved. But over here, we can see the air bronchograms, right? Can you see it? Right? You can see some air bronchogram. There is, clearly we can see some black patches in, right? That means the air is present. Air is present. That's why it has not gone into full consolidation as compared to this. People khatam. There is nothing. That kuch nahi hai. That's what I said now. That's what I said. It is not the fully, it is involved, right? Middle lobe is involved, but not fully. It is not so that every time you get the whole picture. Because we are watching this air. See all these black patches, what we are watching. That is what? It's air. So air is there. Air is present. If the air is present, that means alveoli are okay. They are working. Right? So it is not so that just a flip of switch and whole lung, whole middle lobe is gone. No, it takes time. If you don't treat this patient gradually, it will keep on developing. Right? Similarly, there are two findings in this. This is the left lower lobe is definitely involved. Definitely left lower lobe consolidation. Because diaphragm is not seen. Diaphragm is blurred. Right? Left part of diaphragm blurred. Very good. Right? So diaphragm or the dome of diaphragm blurred. So this we can stamp it. And see, had it been the lingula, if the lingula is affected, so that means it will obscure this left border. Right? So right now, this left border is seen clearly, that means lingula is not affected. Left dome of diaphragm is affected, that means the lower lobe consolidation. Done. Right? See this. What is this? That's right. Middle and lower lobe are middle and lower lobe or right side or nahi. You must have. I got it. Yeah, you're right. So here it is clearly middle lobe. You know the reason, right? Middle lobe consolidation because yes, border not seen, right? Right heart border not seen. Good. And this horizontal fissure, yes, that is seen. So that is also fine. So middle lobe consolidation. Done. One part is done. Second, can you see the diaphragm? Not. Right? Diaphragm is also not seen. So even lower lobe involvement is there. In between, can you see some air bronchogram over here? Can you see some blackness? I just use this. Whenever you see this one, that means that is called as the air bronchogram. It is seen. Correct? That is air. So when we find air, something is. The typical thing in this case is what can you find, say over here, the consolidation में देखा थोड़ा ऐसा mix जैसा picture. There are some black patches. But if you see this lower part, it is so क्या smooth, मतलब absolutely एकदम smooth. Yes, see, मतलब कुछ भी नहीं, मतलब जरा सा भी कुछ नहीं दिखा. Ribs okay, ribs are seen, but I'm talking about the lung tissue. Lung tissue, कुछ नहीं, जरा सा भी नहीं. There is completely no air bronchogram. The thing is, this is pleural effusion. This is the difference. This is fluid. The entire thing is filled up with fluid. So this is not consolidation, but it's the pleural effusion. There is middle lobe consolidation with pleural effusion, right? Because no air at all. As if bilkul paint mara, crystal clear, right? See the difference. This is a beautiful X-ray. You just look at the texture over here and look at the texture over here. Even over here when the consolidation is there. But see, there are some bronchograms here. Because when the consolidation occurs, ऐसा तो है नहीं 100% all the alveoli they are completely blocked, मतलब जरा सा भी air नहीं. कहीं ना कहीं कोई ना कोई alveoli खुले हैं तो, and that air will give this rough appearance, right? Those black patches are there, means alveoli working. हाँ, अरे यार, you don't give this strange logics. Why are you giving this such logic? This much area, right? You don't see this is normal. How can you say there is no consolidation? Some alveoli they will be open, na? I mean, say it is good to be smart, but sometimes that extra component it is not a very welcome. Try to understand. I'm trying to explain in simple words. What you need to understand. See, at times it happens like you don't come across such examples. Simply just watch kitna smooth this area, and this is also fine, but yes, there is some air. 90% there is consolidation. Hardly few alveoli will be there, but they will always be there because they will be giving you the clue that it is consolidation. They will be giving you the clue. This type of patient recovery happens very difficult. This patient who unfortunately passed away. Because there were even other complications also. Even there was cardiomegaly. In this next time I'll explain you even that part also. If you really draw, right, to the size of the heart, that was the massive. So when you compare, there is a massive cardiomegaly. So even there was right heart failure, the lungs were collapsed, there was pleural effusion. It was difficult. Means they are on ventilators. I mean, with this condition, it would be extremely difficult for the patient to breathe. Yeah, they are on ventilators. Oxygen level is critically critical. So this is the pleural effusion, right? And this one is the middle lobe. Patient age, this patient was pretty young, pretty young, 40s. This one, this was a massive car accident, crash injury. Applied the brakes, and with the steering wheel, the patient banged. So you can see multiple rib fractures. Can you see this? And the fracture, these were so big that the broken pieces of the ribs, they entered into the lungs, right? And that lead to massive bleeding. So this, what you are watching, see that this area, this is the bleeding. Right, you can see the air, right? There are air bronchograms which are seen. You can clearly see the air bronchograms. But this is because of, normally when there has to be the air, instead of this air, what are these? This is bleeding. When the blood gets collected, because see these ribs, when the fracture occurs, so these broken part, they act like a knife. They literally peel into, and because of impact, right? So they just penetrate the lung, and that leads to massive bleeding. And that blood typically gets, because of the gravity, right? Patient has collapsed, right? Impacted. So now the patient is sitting. So that blood would be collected onto the lower side. So this is where the blood is coming. This X-ray was taken pretty early, so later on, to even this whole thing blurred. This diaphragm also got blurred. So here, rib fracture and displaced. This is the area of bleeding. All right, so that's it for today. Thank you so much. Patient could not see. Because it was not only this much, this is the heart, but the head also banged. So there was one other in which there was fracture onto the skull. Fracture onto the skull, and the patient died not because of this, patient died because of head injury. All right, so see you soon. Have a great Sunday. Saturday and Sunday. Thank you. Bye. See you soon. Jai Shri Ram. No, head injury. Head injury is bad. When we'll be discussing the X-rays of head and neck. That's why they say that why seat belt is important. Why seat? Without head injury, he could be saved. Yes, yes, yes. You do the thoracotomy and you take this blood out and these ribs so they can be managed. Yes, yes, yes. My X-ray of that lung collapse, I got the CT scan of that because I went for straight away the CT scan. During you're talking about my lung collapse, right? Yeah, I do have the CT scan. I'll show you. Today's topic, it is like you can read from Guyton, not for these X-rays, right? These X-rays, so they are all combination. USMLE lecture day. I mean, no, I didn't get your point. USMLE lecture day means. All right. So thank you so much, and I'm saving this thing. In a minute, I'll share for you. Pleasure talking to all of you.